listening to the Transcend Health Solutions Podcast.
Hello and welcome to Transcend Health Solutions Podcast. I am Courtney Traber. I'm a therapist here at Transcend, and I'm here with...
So I'm Will. I'm the Director of Operations of Transcend, one of the nurses and paramedics here. And today we are going to be discussing basically general therapy questions that we pulled from Reddit, questions that patients might have. Wanted to do a podcast. We've done a lot really focused on ketamine and things like that, but I think in general, there's just a lot of questions about therapy.
Mm-hmm.
And so wanted to bring in Courtney and just kind of go over some of these things, and hopefully it'll be helpful for anybody thinking about doing this treatment or therapy in general. And pretty much expecting this one to go viral. So get ready for, some serious inquiries here, Courtney.
Okay.
This episode is brought to us by the letter K. Use your imagination about why.
Comes after J and before L.
Yeah, that's why. So let's go to our first question here. And we could probably start anywhere, but my therapist told me I have CPTSD, complex PTSD, today. Is this an official diagnosis?
So, from what I understand, CPSD, complex PTSD, is not included in the DSM at this point, but it is a diagnostic code for the ICD. I can't remember exactly what that acronym stands for at this moment, but it's basically a billable code is what that means for insurance purposes. So, yes, it is an official diagnosis, but it is a complicated diagnosis, hence the name, complex PTSD. So basically what that means is that, you're someone who has experienced significant trauma over a long period of time, and sort of like different types of trauma. So it may have been emotional abuse, neglect, physical abuse, sexual abuse, sort of a combination of different types of traumatic experiences, again, over an extended period of time. So a lot of times that is a diagnosis that can sort of encompass a lot of other diagnoses. So someone might have been diagnosed with sort of like a personality disorder, or maybe even kind of like ADHD or autism spectrum, but complex PTSD is something that can sort of, it's the umbrella for all those things.
So if there's complex PTSD, is there simple PTSD?
Yes.
Not so complex?
Yes. I think the diagnosis for that in the DSM would be acute, PTSD acute, as opposed to chronic. So that would be just like there was a specific traumatic event, more of like a single traumatic event that's resulting in the PTSD symptoms.
In relation to kind of addressing complex PTSD versus PTSD, I guess, is it appropriate to say normal PTSD, or do you just say PTSD? It feels weird to say complex.
PTSD.
Yeah.
Yeah.
Okay. Is there sort of a difference in approach or expected, sort of treatment plan or anything like that in relation to PTSD versus complex PTSD?
Yes. So complex PTSD, I'm speaking from my experience working with clients who have complex PTSD. I'd say that typically, unfortunately, you could probably expect that the treatment is going to take a bit longer, like especially when we're talking about KAP. Usually we estimate that a person with complex PTSD would probably have a series that's more of about like 8 to 10 infusions with maintenance, most likely afterward. And also, it's probably going to be recommended that you do integration sessions and you're doing regular talk therapy throughout the course of your series. Whereas if it were acute PTSD or more of like a straightforward PTSD case, it might be more of the average of like 6 to 8 sessions. And usually it's gonna entail more like relational work with the therapist of sort of like repair of attachment wounds and things like that, as opposed to acute PTSD where it may be more focused on just like, again, that specific event and reprocessing some of that trauma.
Yeah, I've definitely seen that to be the case as well, that those that either are presenting with complex PTSD as kind of the primary thing that they're working on, or those that sort of have both, that there are maybe other traumas as well as complex PTSD. I like to say the longer that this has been going on, that might influence, how long it takes for it to, kind of budge. And so I think that kind of makes sense, or the earlier, So now, what do you think about the term PTSD? Sometimes I see people averse to using the term disorder. They'll call it, just post-traumatic stress. What are your kind of thoughts or preferences around that terminology?
I mean, whatever terminology the client feels comfortable is really what I try to match. I'm not a huge fan of like talking about diagnoses with the clients unless that's something that they feel like is really helpful for them to be able to have a label or sort of like an umbrella that helps them to understand what they're experiencing. I don't necessarily have a problem with it.
Yeah.
I think that it's just a helpful acronym that sort of sums up a whole plethora of symptoms.
Yeah, and I mean, that might be worth talking about a little bit too, just the utility of diagnosis, where it can be helpful, where it can be harmful. I know that, I think we've spoke about this before, but in general, the way I like to think about a diagnosis is it's clinical shorthand. If you were to talk to another clinician and you were trying to describe a case, you could easily say this person has complex PTSD and depression or psychothymia or whatever it is. They would get a general picture in their mind about the person that's going to be coming to them. That seems to be, versus trying to start at this person's, life story and specifically what has been kind of more going on for them. That's really diagnosis's main utility. And I think there are times where receiving a diagnosis can feel, well, it can be different ways for different people. And sometimes it can actually kind of stand in the way, and sometimes it can be helpful. Do you have kind of any thoughts on just receiving a diagnosis or accepting a diagnosis, where it's helpful, where it's harmful?
Yeah, when I was working in private practice and a client was, just felt very confused about what they were experiencing or even how to approach treatment, medications, things like that. And they really wanted to have an assessment and kind of go through that diagnostic process. I would always have a conversation with them about like, what are you hoping that receiving a diagnosis would do for you, right? Like, what is the intention there? Just talking about what the diagnosis means for them. And then would actually kind of go through assessments with them or go through the DSM diagnostic criteria and talk about all the symptoms with them and how it shows up in their life. So that's how I approached it, just as kind of a private practice clinician. But when I've worked more in like inpatient settings or, like at Transcend and you are helping clients or providing them documents for reimbursement, things like that, diagnosis is much more important, obviously. So, and usually here clients are already coming in with diagnoses. They've been through quite a bit of mental health treatment before. So it is approached a little bit differently here, just as far as, trying to help clients with billing for insurance, and they're usually already aware of their diagnosis. But I do have conversations with clients about like how do they relate to their diagnosis, because sometimes they've been diagnosed with PTSD in the past but didn't like know that they had that diagnosis, and they're not using that language that they've experienced trauma. And so in those cases, I'll kind of talk with them about what trauma is and what that means, and just help them to identify with it in a more helpful way, if that's possible.
How do you like to conceptualize or define trauma?
That's a big question.
That could be a whole podcast.
Yeah. Yeah, I think Anna also did a podcast, so anyone who's curious to go more in depth on that subject can definitely go listen to that one too. But I think trauma is basically when you experience something that basically it exceeds the coping skills or resources or supports that you have at that moment to process and deal and regulate after that event. So some people may experience the same event, but it won't be trauma for one person, whereas someone else may have a traumatic response to it.
Because it exceeded someone's coping skills at that time.
Mm-hmm. Yeah.
It's a good way of kind of framing it. Yeah, I think that very oftentimes trauma, some things that can be that are, objectively traumatic cannot register as traumatic for some.
Mm-hmm.
And sometimes things that don't feel like they would be traumatic for someone can be, have a huge impact. And so it's sometimes when we, I guess, conceptualize trauma and use that term, it's like it creates this super high bar, that sometimes is hard to identify with, or see things as trauma.
Yeah, it's so specific to each person. It's more about like what that event mean to you specifically.
Yeah, I know that there are some ketamine therapists that actually will publicly say that, KAP is not useful in the treatment of trauma. It's pretty much most of what we do at Transcend. So I would like to say that we've got thousands of case examples of that being incorrect. That, trauma can definitely be addressed, in KAP, that there is that is a possibility and coping from that, as well as that it's definitely best to be working with a therapist for someone looking to work on trauma with KAP. There seems to be a good amount of data that going over that trauma, that may be a weird way of framing it, but in and around the ketamine process is required for patients with PTSD to see a meaningful response from the process versus just receiving ketamine. It might be possible, and for someone maybe with just a treatment-resistant depression diagnosis to receive ketamine and experience some reduction in symptoms. But we really don't expect with PTSD or complex PTSD to have a massively clinically meaningful response from ketamine infusion only without paired psychotherapy. There's good amount of data to suggest that. And so
yeah, I mean, I would even say that if and we've had clients intake who have had ketamine infusions at another clinic without the therapeutic support, who have discussed feeling like they were re-traumatized, basically, because that relational aspect of it is so important, having a support there with you. Like in those specific examples, if when they were alone going through an infusion, I can think of a couple of specific examples, like they were having some of that, some trauma processing come up, and then they reached out for someone to support them in that moment, and no one was there. And so those were instances where basically you're just reinforcing that those beliefs that were born from that traumatic event, right? So it might be the belief that like the world is unsafe, or I'm alone, or basically there's no one there to help me. I'm in this on my own.
Yeah, and I think that it's a missed opportunity for kind of more of a corrective emotional process there that could have taken place, but instead it was actually kind of re-solidified that that I'm in this thing alone.
Yeah, that I don't have enough resources, or I don't have the coping skills to deal with this experience now, and so it can just kind of compound.
Yeah. Well, our next question is basically looking at how to discuss suicidal ideation with a therapist. So when I've pulled the numbers in the past, somewhere around 75% of our patients elect some form of suicidal ideation, more passive or chronic in nature on intake. And, it's a big part of KP and what we do. Obviously, managing some of these things in the outpatient setting, it can be a challenge, but our patients are coming looking to, I'm thinking these thoughts, they're scary to me. I don't want to be dealing with this. And I guess where I'm going with that is I think sometimes, there can be an aversion to discussing this out of particular if anybody has ever been sent inpatient for discussing suicidal ideation in the past. I guess if you could kind of speak to working on suicidal ideation, that process, what are the norms of therapy around all of this?
Yeah, this is actually a subject that I care deeply about. After working in inpatient settings, that was, just how inpatient settings tend to deal with suicidal ideation was just really difficult for me to swallow. There's just so much bureaucracy around it. It's like the second someone mentions that they're having suicidal thoughts, you have to go through this whole protocol, and there's really no helpful discussion, at least from what I experienced for a lot of clients when they're in those types of settings. And so it was really important to me to get to work in a setting where you were more able to discuss that openly with clients, because I think just having the space to talk about those feelings of hopelessness and just like dread about existence is so important to actually working through those mental states and getting to the other side of it. And a lot of times, clients will just sort of dive into that and fully feel it. And for some reason, like that is the most healing thing, not treating it like it's a problem to solve, but more just letting them express it and have someone who they feel understands it and can sit with them in that space.
Yeah, I've definitely seen that to be the case as well, sitting in on sessions. I remember in the very beginning, kind of hearing patients more fully vocalize, the depth of that. And, coming from the mainstream medical nursing world, if a patient said that they were suicidal in the ER, it's like, the bells and alarms go off. Yeah, everything changes as soon as someone says that. And it's a really bizarre process that definitely doesn't seem helpful for anybody because there's no space to talk about what's going on. It's almost like they, came in and said, I just robbed a bank. It's,
it's treated like a crime, really.
Yeah, it's a really strange environment, for that. And, I think that we do a really good job of allowing patients to openly discuss that. Now, obviously, if someone, said, if I go home today, like I am going to kill myself, that's a different situation that we really probably do need to plan a
Mhm.
situation where someone can be safe during that period of time.
For sure.
But it's definitely not our intention to, just because someone says, hey, I'm, thinking about killing myself sometimes, this is coming up
Mhm.
for me more regularly, or it's, um, this is something I'm dealing with, that we can't have an open space to talk about, you know, that process and those
Mhm.
thoughts.
Mhm.
And just giving it a space to, like you said, kind of more fully not only feel it, but let that part kind of speak.
Mhm.
Sometimes is just all that's really needed, because it's so repressed, it
Mhm.
seems, to be able to tell anybody that that's going on,
Yeah.
and
Yeah, and I mean, if you think about it, if you don't have a space to discuss that and go into, basically the decision of whether you want to continue to live or whether you want to die, then um, that that cycle is just going to repeat itself.
yeah. So next question, um, says fear of choosing the wrong therapist.
Mhm.
So I guess this person's just asking, if I intake with somebody, and how do I know the fit is right? How do I know that I will progress with them? Could you speak to that kind of concern?
I think the number one thing is just being curious about how you feel around them. Like, do you feel comfortable opening up to this person? Do you feel that they are trying to understand you, that they are hearing you? Do you feel seen and heard and safe? Um, I don't know if there's a really concrete answer for that, of like specific things to look for. I think for me, I would just encourage clients to really be mindful about how they're feeling in the room with their therapist. And it may take some time to be able to fully feel that out as you're getting to know each other. And so I think it's also important to remind yourself that it's okay if you are not feeling that way with the therapist. It's okay to leave that therapeutic relationship and try to seek another provider who does feel safer for you.
Yeah, I mean, I've had a number of therapists over the years, and when I finally intaked with a therapist that I really clicked with, that's kind of exactly the way it felt. This felt different. I feel like
Mhm.
I can talk about anything. I don't feel a big hesitancy to bring something up that's bigger.
Mhm.
I it was definitely more of a felt sense than something that was more logical.
Mhm.
Just something that I noticed.
I guess a caveat to that though is I would also encourage people to, like, if you do feel discomfort, to bring it up with a therapist, because there may also be some therapeutic work there in the discomfort that you're feeling that you might be able to process together. Right? So maybe your therapist reminds you of someone from your life who you had a difficult relationship, and if you bring that up, you might be able to work through some of that stuff.
Yeah, I curious too, in relation to picking therapists. I think a common one is kind of male versus female therapists,
Mhm.
and a male or female or otherwise identifying client. Um, is there, how do you feel about, that sort of dynamic?
There can definitely be different dynamics for sure. I think it just depends on where someone is at in their kind of mental health journey, right? Because if you have, let's say, trauma, childhood trauma that was very much connected to your relationship with your father, you may not want to immediately seek as your first therapist a male therapist. But as you work through some of that stuff, maybe with a female therapist, you might get to a point where it feels like, okay, I'm ready to kind of work through some of those challenges around dynamics with a male.
Yeah, I recall a session that we had recently where me and a male therapist had supported a female client through the process, and she was, kind of reflecting on how important that was, that she had a big aversion to, being in the room with two males, and kind of processing
Mhm.
some of what she was working with in that setting, but how, with the obstacle being the way there, that there was so much more that kind of came out of it than years of therapy that she had had, kind of with female therapists. So
Yeah.
if there's an aversion there, it sounds like it's something to listen to, but it also potentially could be that aversion is just signaling that there may also be potential there too.
For sure. Yeah. And I think that, again, that's something maybe to discuss with your therapist, because there's a time and a place where it's probably going to be really helpful to challenge yourself and kind of do that thing. Like you're saying, the obstacle is the way. Do the thing that feels hardest.
So, in relation to picking a therapist, there's a question: what are the different types of therapists and different approaches? And is it important to know a therapist's theoretical background? How important is that? If someone has, a specific diagnosis, that their therapist is, using a framework that fits that, or, I guess if you could speak to that.
Yeah. So I think in some ways it is helpful to know your therapist's theoretical background, and in other ways it's maybe not so relevant, because some of that is just what your therapist is using internally to kind of conceptualize and come up with a game plan, basically, of how they're approaching therapy with you. But I think the piece that is important for clients is if they know that there is a specific way that they work well with people. Like I have clients who do really kind of thrive when they have a more structured format in therapy, and it's more solution focused, and you're very specific about goals, and they want homework and things to do, very concrete things. And then I have other clients where, if I were coming at it from that approach, it would just not fit well with them. Also, there are different approaches, like DBT is really good if you're really struggling with distress tolerance, right? And more behavioral things of like, it's just really hard for me to get through my day with the emotional kind of intensity that I'm experiencing in the day to day. So in those cases, something like DBT would be more helpful to manage some of those things just right away, as opposed to more just like psychoanalysis where you're just analyzing your internal world, but maybe there's not as much kind of hands-on intervention.
Yeah, I think that it's probably really important that if in therapy someone feels comfortable to say, what we've been currently doing, I'm just a little curious if we could be a little bit more like this, or, we could kind of change. I found in my own personal therapy journey, working with therapists over time, it's been much of a process of kind of both figuring out, me learning how to do that process as well, how to get started at a beginning of a session, where at the end of the session, I feel like I actually kind of got to cover things that were actually relevant, not just down some rabbit hole. And so, I've asked, can you please let me know when I'm down a rabbit hole? And actually, sometimes, my therapist is like, well, I think sometimes you end up in a really good spot when we do kind of chase a rabbit hole sometimes. And so there may be times where we can do that, where I actually kind of am a little bit more guiding you through that process. Or I think there's other times where that's really useful. And so sometimes even just electing, hey, maybe we could do this different. It got the opportunity to hear, well, actually, although that's my idea of what might be useful, but you've been watching me do this process this whole time, and you're actually seeing something I'm not, which is that I actually do end up in more rich territory sometimes when we just kind of allow it to be a little bit more free. So I think conversation around, approach along the way is really good, and sometimes can be, oh, this person does need, more of this. I think most therapists can kind of bend to what is required or what would be helpful.
Oh, I always appreciate so much when clients, talk about things like that. And And I think, again, that's why having that core, that foundation of feeling safe with your therapist is so important, because that it's an interactive, like shared parallel process that you're going through together. And, I can't read the client's mind. I might think that something is working well for the client, and internally they are just not finding it helpful at all. And, vice versa. Like you're
But you would
saying.
want to hear that.
Yes.
Yeah.
Yeah.
Yeah, I think that sometimes that can be like, oh man, I don't want to upset my therapist's feeling or make them think that they're not doing a good job with me because I actually really do like them. I just, kind of want to bring this thing up.
Mm-hmm.
And I find that probably most therapists would find that as an opportunity,
Mm-hmm.
to actually kind of deal with one of those more interpersonal
Mm-hmm.
things in a
Yeah.
safe place.
Yeah, because, like if we're trying to meet you where you're at, but we don't know where you're at, then that makes it really, really difficult for us to do our job.
So, is there I think we talked about a few of the different kind of more theoretical approaches and styles, but in relation to just kind of different types of therapists and, some of the more, in other words, like maybe we could just get to different types of therapists and different types of frameworks more broadly and kind
Mm-hmm.
of what's more useful in KP.
Yeah, I'm trying to figure out where to start. Since this was the last question, what's more useful with KAP? I think just sort of a psychodynamic approach, which that's sort of a catch-all. It just basically means that you, again, will meet the client where they're at, and you have some knowledge about a lot of different approaches and styles, and just kind of try to match what works best for the client. Just because KAP can be so unpredictable, and you're seeing so many different types of cases, or lots of different types of populations, just like a huge range. So it makes sense that you would want to have a huge range of just kind of conceptualizations or styles that you're in your toolbox. But also IFS, internal family systems, seems to work really, really well with KAP. The language that they use in internal family systems, it's really interesting. It just seems to like come up naturally for clients and experiences. So the general idea is that we are sort of made up of all of these parts, that we have a whole system within us of different selves, if you will, that are constantly interacting and taking the reins at different times in different situations. And so it's learning how to integrate all those parts and kind of coexist with all of them.
Yeah, I think that so in relation to that, I mean obviously KP, that is a specialized modality in and of itself. That's why I think sometimes that question about which therapeutic modality is smartest for KP, it's like, well,
Yeah.
KP is is a framework in and of itself,
Yeah.
how you work with it.
Mhm.
So obviously that includes and blends in a lot of different things, but it
Mhm.
is sort of its own thing. If we were
Yeah.
to compare it to,
Yeah, it is.
martial arts, it's the mixed martial arts, right?
Mhm.
And,
That's a good point.
yeah,
Mhm.
in mixed martial arts, you might do, Muay Thai and jujitsu and wrestling and boxing and all these different things together. But, mixed martial arts is a type of martial art. And so
Mhm. Mhm.
similar with KAP, I guess. So I guess where that question was kind of going is just that, someone was asking, if I already have a therapist, why do I need a separate ketamine therapist?
Mhm.
I guess if you could speak to that, because most of our clients have a therapist that they see outside, and then they're considering this treatment. And I think that's a common question of, well, I already have a therapist, so
Mhm.
why do I really need to, have this other therapist and kind of intake with this other person for this process?
Mhm. So, I mean, like we were talking about earlier, just first of all, it's really important that you have a therapist in the room with you. And more specifically, to have a therapist who has experience in KP. right? Because it is a different style and a different approach. Like the way that I am with clients, how I approach it in the actual infusions is different than how I approach therapy just in talk sessions, even at Transcend. So yeah, I think that's the number one thing. Also, it's an intensive, short-term treatment is the way that we're approaching it. So kind of separating a little bit from your ongoing therapy, I think is important as well. Because the goal with KAP is that you're not going to be coming forever, especially not every week. And so I think having a little bit of separation there where you can process what's coming up in KAP specifically with someone, but you're not seeing them on an ongoing basis can actually be really helpful.
So, totally agree. I think it's really important to work with a ketamine trained therapist, in and around this process. It definitely is the case that there's a lot of norms of ketamine therapy that, unless you were well trained in this, might look really abnormal. Kind of really one of the ones that comes to mind most immediately is just that it's not uncommon. Obviously, this is quite a bit more intensive of a process, but not uncommon for some distress to be kind of stoked along the way, where to a KAP trained therapist, that we know exactly what that looks like. We see it over and over again. We see the exact same transitions time and time again, and we can kind of gauge what somebody's capacity to more fully go in on a session or not. And learning that process, it's probably a challenge for someone who didn't have this training to kind of hear the content that's coming up from the sessions and really know what to do with it, because some of it can be so obscure. And so it's, I think, definitely the case that someone should work with someone trained in KAP if they're going to engage in this alongside their normal therapy, which we think they should continue normal therapy, and of course after discharge continue that process. We always try to if someone isn't currently engaged with a therapist, and they intake, to get that taken care of prior to discharge.
Yeah, I usually recommend, if someone is already engaged in individual therapy, that they schedule their individual therapy session like the day after their infusion, just to have ongoing like integration and processing around it. But yeah, when I started doing KAP, it was definitely like a steep learning curve, and there have been a lot of things that have shifted around my style and my approach to it in the actual, infusions.
Yeah, well, I've definitely seen you grow a whole lot, over this period of time. And so last time I asked Courtney how many sessions she thought she did, I think she said like 50 or something. I was like, oh my God, it's like so much more than that. Her concept of how many sessions she's done.
Concept of time gets weird.
Is it a year and a half?
Yeah.
Yeah. So
I think about maybe a little over now. I still don't know how many sessions I've done.
Well, 5 or so a day and a year and a half. So
Someone do
it's
the
a lot of
math
work
for us.
So this question is about how much do I need to focus on my past in therapy? I think a lot of people, it'd be a common, idea, what is the utility in kind of looking to the past or just kind of going through that in therapy?
I think it's important, right? Because we're always carrying the past with us. Like, it's always a part of us. We're constantly reprocessing our past and glancing back at it. I like the analogy of, when you're driving, like, you need your rear view mirror, you need your side mirrors, right? You need to be glancing behind you and beside you, but you don't want to be just constantly looking in your rear view mirror and not watching what's in front of you. So that's kind of how I think about it in therapy, is that we do need to glance back there, because what happened in the past and how you're like the story you're telling yourself about it is playing a part in how you are in the present. But getting stuck in it or focusing on it, fixating on it is usually not so helpful, and that's usually where depression kind of falls.
So in that, I think a really common one, and there's a question about just kind of what is the point of talking about issues? How does talking things out? What is the point of
Mm-hmm.
just telling someone else what's going on? How could that possibly make me feel better? I think is a
Mm-hmm.
pretty common one. What is your kind of thoughts around this?
I think it always surprises me how much it can do for someone just talking about it. Like I'll have a client come in and they're so distressed and they sit down and they, just vent for a little while. And sometimes they'll be like, well, I feel a lot better now, and to me, it didn't really feel like we had done anything yet, but just the act of verbalizing it, of pulling it out of their mind and putting it into reality, and being able to observe what has been running around in their mind for a while is reparative, or helps them to sort through some of that stuff and organize. So I think just putting a name to things a lot of times is really helpful. And also there's that relational aspect again, right? So having someone who is unbiased, ideally, maybe sometimes you find a therapist who feels pretty biased, but ideally they'd be unbiased, a third party who is really just there to support you and kind of reflect what they're hearing from you in the moment, can be so helpful, right? As compared to if we're asking advice from like friends or family. And then there's also that like mirroring aspect of it. So having someone who can remain calm and who's not emotionally getting pulled into what you're sharing can be really reparative for your nervous system, and kind of co-regulating with a therapist who is able to remain grounded and regulated when you're distressed can be helpful too.
So that definitely makes sense. So here's a question about what could I do before and after a therapy session that would help with this process to be more successful? And we could make that about ketamine treatment or just kind of therapy in general. What would be kind of your tips on that?
Self-reflection is very helpful. So outside of sessions, just trying to be mindful and trying to be curious about what is going on internally for you. So your thought processes, your emotions, sensations in your body, how you're reacting to things in the day-to-day, so that you can come into a therapy session with some amount of awareness about what was distressing for you that week, what was helpful for you, where you struggled. When clients come in and they don't have anything to talk about, that's okay. You don't have to have, a specific problem each time you come in, but at least kind of starting to practice that, what's it called? Just that internal curiosity about what you're experiencing is really helpful to the process. And then also just any types of self-care strategies or kind of concrete behavioral stuff is helpful. So things like breathing exercises or going on walks, getting sunlight, interacting with friends or family, things like that are going to be helpful as well. So trying to challenge yourself a bit between sessions.
So there's a question, what does it mean to be engaged in therapy? I guess what does that mean to you?
So I think that also entails the self-reflection piece. So you know yourself better than I ever can, or than I ever assume to. You have so much more data, right? You can actually turn inward and experience what's going on for you and have more knowledge about that than I ever will. So I think engaging in therapy is just that willingness to be curious, to want to gain self-awareness, and to recognize that you are an important piece of the process. That I don't know what's best for you or what you need automatically, that I have to have some input from you to be able to support you and kind of walk through the process with you.
So in other words, you can't like therapize somebody. You can't like
I can't read their mind.
do it to them.
No. I can't do it for them. I can't do it to them. I can't drag them along. And it's not helpful if I were to ever try to do that.
Yeah, I tend to think that as I've gone along in the therapeutic journey, it's kind of like I've learned more about how to do therapy. It's kind of almost like a muscle you learn to flex or something like that, to become more and more comfortable to go through that process and learning how I process, and just getting it to the point where it's a little bit more useful for me. It can be a really hard thing to kind of learn and do, especially if someone who's never really done it too much, or maybe they have, but just kind of past therapy just hasn't had a lot of utility. So feeling worse after therapy, someone has a question about, they're, I guess, kind of discussing that it feels like the therapy's not working because they're feeling worse after. I guess, could you speak to
that? Means it's working.
Yeah.
Unfortunately. Yeah, I hate to be the bearer of bad news, but it'll probably get worse before it gets better.
I'm starting to think you don't hate to be the bearer of bad news, because I think you say, I hate to be the bearer of bad news fairly regularly in the room. And I'm like, maybe she does.
Because I know that it's good news, but to them it's going to be bad news.
Yeah,
it's uncomfortable, but yeah, that's a signal that something is happening, that there's movement. If you want things to be shaken up a little bit and stirred up a little bit in therapy, because you're trying to reprocess some of these beliefs and thoughts and experiences. And so that's just kind of what change looks like, is you have to get a little bit more uncomfortable to change.
Yeah. I think that is there any time that wouldn't be the case? You're feeling bad after and it's not productive. Is there anything that as a therapist that flags to you that, no, this isn't just normal distress that comes up from, kind of facing some more challenging things. This is actually just purely dysregulating with no purpose or something like that. Is there ever a time that is not true?
Yes. So I'm thinking specifically about KAP. So there may be times when someone does have a lot stirred up, and this is an important lesson I learned working in this setting, is that your environment is so crucial. Like, what's going on in your environment, how stable and safe does your environment feel is really important when you're going through an intensive treatment. So if something gets stirred up and then you go home and you get into a big conflict with your spouse, and you don't have any help like caring for the kids, and they're running around wild and crazy while you're trying to process all this stuff, you may get kind of pushed over the edge, and it may just feel like too much, and that's probably true. In that case, it's probably not so helpful. So making sure that you have space to regulate and take care of yourself after a session is really important. And I think that goes for talk therapy as well.
Yeah. So this question, my therapist brought up a potential discharge date, and I feel so many things, and they have kind of a long, bunch of questions about that. I guess, obviously when we have patients come through, we may see them, 6 or 8 times, and they may never see us again after that period of time. And there's so much rapport that is built in this process. And sometimes people have gone over things therapeutically that they've never done with another therapist. And it can be a real challenge to navigate feelings around that process of this being kind of a transient thing.
Mm-hmm.
I was kind of wondering if maybe you could speak to just that process of kind of discharging in therapy. And
Yeah. Well, I think it's important to know that it's hard for the therapist too. That's always hard when I'm saying goodbye to clients, especially in KAP, when like you're saying there's so much rapport and um, just this felt sense of closeness and vulnerability and trust in such a short amount of time. Um, so yeah, there are mixed emotions on both sides because that's the goal, is that someone doesn't need to come back, but it's also a really difficult part of the relationship, just like it is in most of our relationships for most of us. The idea of saying goodbye or the end of a relationship is something that's really difficult to accept and brings up that whole grief process. So I think the number one thing is that it makes sense that you're feeling that way. It's important to let yourself feel that and to talk about it. Because if you do allow yourself to do that, then you're probably going to be able to work through some of that material that comes up for you in your life with your relationships. And it may feel easier to um, say healthier goodbyes and have healthier closures in relationships.
yeah, we have this fun process that we do at Transcend when we have someone who's now subclinical and they're on their last session, they're discharging.
Mm-mm.
We have this tiny gong that I was planning on ordering a big gong, and then it came and it was really
miniature.
small. And so it was even funnier because, we're like, all right, let's, do this. And we ring the gong and it's just like, "Ding!" Like it's just not, particularly overwhelming. But I think it kind of does, to almost celebrate that or more ceremoniously kind of close, the process in kind of a more fun way.
Yeah.
I think is pretty helpful. But,
Mm-hmm.
we always ensure that people know that they can reach out at any time, that, we're taking a break for now, for sure. If things come up in the future, not only are we going to be following up with you to ensure, but that it's always okay to return to this if needed. That may not be required. And that is kind of the unknown of it sometimes, that, life can really happen and put someone back to a similar place that they were in when they originally were seeking this treatment. And there may be a need to do a few, but what I've seen kind of time and time again is when we do discharge someone subclinically and then some time goes by, maybe they go through a divorce or maybe something happens and they're like, things are pretty rough for me now, and they want to re-engage. We're like pumped to see them again and happy to see where they're at. And generally, when patients do come back, and I've seen this over and over again, where if we have their intake questionnaire, the level of distress that they were at on intake, and then we get someone subclinical. A lot of times when they're like, things are really rough for me again, when we get that read for where they're at, very oftentimes it's much lower than their original intake level of distress. But it's like that needle has moved for what feels like things are really rough again. It's like, well, this is feeling really rough right now, but it's actually still like half the level of distress that you had a year ago, when you first intaked with us. So even though things are flared, we have not, flared nearly as high as it once was. And I've seen that kind of time. It's very rare to see someone kind of spike to that same level of distress, again. Well, a little bit of time for maybe one more. I have a fun one. Does speaking to yourself in the third person give you multiple personality disorder?
I like this. Short answer, no. That's actually a very common thing to have. What is the statistic? I just read this recently that I think it's half of people do not have an internal narrator. Is that right? I feel like we were talking about this recently.
It's half.
I think it's half. Maybe it was a little less, like 30%, but not everyone can do that as easily internally. And so it's pretty normal for some people to be doing that externally, just kind of narrating your experience and walking you through life and your day-to-day stuff. Even
Yeah.
though to other people it may seem a little bit odd sometimes.
Do you ever feel that sometimes people gain a little bit more insight just around parts, and then I guess because of, maybe social media or otherwise, they're like, I have multiple personality disorder. I'm recognizing that I feel different ways at different times, and it sort of is actually just kind of more of a recognition of a process that everybody experiences,
Yeah.
but can feel like a disorder, as it becomes aware to somebody.
Yeah, with DID, which used to be called multiple personality disorder, you wouldn't be aware of your different personalities. Whereas with what we're talking about, just that awareness of different like parts of ourselves, you can be aware of that, and you can actually have a sense of those parts kind of interacting and the tug of wars that go on between those different quote unquote selves. So I think that's the number one thing. If you're aware of these different parts of yourselves and their differing wants and needs, you probably don't have DID.
So if they're asking that question, probably the answer is
Yeah.
no, they've got the awareness.
Mm-hmm.
Well, I think the last one that we can probably cover here is, do I need to have goals in therapy? How important do you feel that it is that, someone just, sits and lets the process kind of unfold as it is, or really kind of have more specific therapeutic goals that they're aiming to achieve and being focused on working on those? What do you feel is kind of more useful or more productive?
So I have to give the therapist answer of it depends. It depends on the setting, the context for sure, because with KAP, it's definitely more important than maybe some other settings or contexts to have specific goals, because it's an intensive short-term treatment. We don't have a ton of time really together to be processing things. And so having a target and having focus and having intentions is really, really helpful. Whereas in just individual talk therapy, like the mindset I'm coming from, I don't think that's quite as important, or your goals can be a little bit more abstract or broad. Like someone may just have the goal in talk therapy of like, I want to gain more self-awareness, and I think that's a perfectly fine goal for talk therapy.
Yeah, and I guess sometimes I've seen where obviously goals can shift through the process, because what was within somebody's possibility when they were in their lowest state, more options may present themselves, where when someone intakes and they're highly distressed and suicidal, their goal kind of most immediately is like, I really don't want to be feeling this bad, right now. And then sometimes we're able to make an impact in that pretty quickly. And so then it's like, sometimes it can be like the goal shifts, where now there is, more of an opportunity now that I actually have the capacity to kind of engage more fully in actually picking a goal than other than I can't exist this way. Then it becomes a little bit more of a possibility to be a little bit more focused.
Yeah, for sure.
But sometimes people come in, we had a session recently that was sort of this way, where someone actually did a series, and then, 6 months went by and they kind of reached a little bit of a plateau or a little block in therapy. And they came in for a KB session specifically about, kind of that blockage that they were reaching. I tend to think that's like the best possible utilization of maintenance treatment. When someone's engaged in normal therapy, there's something that comes up that, no, this should probably, this one's a little bit too challenging to face just in the normal therapy room. I want to address this with KAP. I tend to think that that's just a really wonderful utilization, but that's kind of where you see when someone came in, that original series might have just been really focused on trying to get to a better place. That may involve, addressing a lot of things, but sometimes it's like later on down the road, now there's much more of an opportunity, to really be more specific, and that comes out of that process of continuous therapy, where we are a little bit time limited in KAP. So it can be a little challenging sometimes sometimes we get to the core of things pretty quickly, with this process. But then standard therapy continues on after, and in that process, sometimes it's like, well, actually there's kind of more of this core that was there.
Yeah. Goals are definitely something that you have to continuously reevaluate and check in on.
Well, I guess, that's why we spend a lot of time focused on forming intentions and, being intentional about the process. I think that ketamine experiences can be very different, but they're very subject to, set and setting variables, and utilizing it intentionally, although ketamine may have its own train track and take you on its own path that ends up somewhere else, at least attempting to use it intentionally, in that process, chances are it's going to have a whole lot more utility than just kind of, I'm just going to make it through this one, or, not really having any kind of clear goal set for what that session actually is.
Yeah.
That being said,
you may need you need something to be reminded of, or it's a lot helpful if you have something that you can return to, just some sort of stepping stone or mile marker, whatever analogy you want to use.
Yeah, it's particularly important with ketamine treatment because sometimes patients will get kind of halfway into the session and the question comes up like, what are we even doing? I forgot what I was even doing today, or whatever it may be. And even though we had formed an intention, the ability to kind of return to that, they're like, oh, that's right. That's what I'm doing. Because sometimes it can get out there to a degree that even just a few minutes goes by and I don't even remember what the purpose of this is, and so an ability to kind of return to that intention, it may give a little bit more opportunity for it to be a productive session.
For sure.
Well, Courtney, I guess that's all we got to do. We're going to go back to seeing some patients here. So I know that we've got a few of our past patients to listen to this podcast sometimes, so really glad that y'all are doing that. Anybody who is considering seeking treatment, feel free to contact us. We can always consult with you for free. If you want to work with Courtney, she's obviously amazing. One of our highest requested therapists here. So hopefully you got a taste of kind of how she is as a person. And so what's our sign off for this one?
Hasta la vista.
Hasta la vista.
It's the first one that came to me.
Okay.
Feels right.
We'll go with that for
Hasta
today.
la vista, baby.